So good morning, everybody. Welcome to our next webinar. I'm just going to let the attendees log in. We're just passing 200, 250 and climbing. So we'll just give people time to log in. Very good. Well, look, I will kick off. First of all, welcome, and thank you very much for joining us. It's the second of our webinars. This one is around workforce, which is very much the challenge at the moment. We have a hard stop at 11 because there's a coronavirus minute of silence, which is paying tribute to care workers and NHS staff at 11 o'clock. And so far, there have been 84 health workers who died of coronavirus, 69 NHS, and 15 care workers. So in some ways, it's a highly appropriate thing that we should be stopping at 11 o'clock for that. I think what we're going to do to start with is just run through a few housekeeping things and set the scene. So I've got a few slides to share with you, but I'm going to start by thanking our partners, and particularly Bevan Brittan, who are partnering with us and very much a key part of the content for this webinar. Our media partner is Care Markets, one of our journals, and we have a coronavirus toolkit, which is available free online with lots of useful information for everybody. And then our two charity partners are Turn to Us and the Care Workers Charity. Turn to Us is partnering with the Daily Telegraph at the moment. It's raised over £2 million and it's giving £500 grants to people who are in need. And the Care Workers Charity is doing very similar things for the care workers and has raised over £300,000. So two very worthy and appropriate charities, and encourage you to make a small donation, given that this webinar is free. So in terms of setting the scene, we had a Twitter poll which we ran ahead of this webinar, and the question on the Twitter poll was, what's the biggest workforce challenge? And I think this whole webinar is going to split into two pieces, really. One is more of a sort of a medium-term outlook in terms of how workforce is going to be impacted, and the second is more of an immediate operational challenge. And you can see from the result of the Twitter poll that testing and PPE are very much the immediate concerns of the sector, which is unsurprising. It goes to workforce safety. But you can also see that funding is increasingly becoming an issue, because if you're buying PPE at highly inflated rates, if you're having to hire additional staff to cover for staff who are self-isolating, you are incurring significant incremental costs. And then also the recruitment of new staff. So in terms of just managing the Q&A and the polling, we're going to use Slido again. And to use Slido, you need to open up a web browser. And it doesn't really matter what it's on. It could be a laptop, a tablet, a smartphone, or the computer that you're using at the moment. And then you simply go to slido.com in your web browser, and it will come up with a box where it says event code and it has a hash. And all you need to do is put in the word workforce. And what this will do is take you into the Slido with our polls and with our Q&A. And if you've got any questions, just type them in on Slido. They'll be moderated, and then you can vote them up or down. So the questions that get the most votes will come to the top of the list, and then I will put those to the panelists. And that way we have a way of identifying the ones that are of most interest to the attendees. So I'm going to run a short poll to see how many of you have managed to actually log in. And we've changed the questions a little bit, but hopefully you can see there the poll is running already, and 41 of you already voted. So the questions we've asked are really, in some ways, rephrasing the questions we had in our Twitter poll. And it's really around workforce safety, which goes to PPE and testing, workforce supply, adequate funding for services, And actually the other one, which I think people are starting to think about more and more, and Mike's got some interesting thoughts on this, is actually business viability in the medium term, especially if you're a care home operator and you potentially got occupancy challenges in due course. So I think we'll let that run in the background and just carry on with the slide presentation. If you look at some of the themes of the questions that we were asked by people who registered, some of them were very much around market outlook. Will care workers get a pay rise now that the value that they bring is more apparent? Should there be a Royal College for care workers? Will the NHS use care workers as part of their resource and their wards in future? Will private equity-owned care businesses actually have a future in a post-COVID service configuration? And how does digital work? Digital DBS checks, who's going to run them? Are there other tools out there that are useful? But actually a lot of the questions are very much around operational and practical questions that people are dealing with today. And I know Jodie Sinclair, who's a partner in the employment team at Bevan Brittan, will be answering a lot of these as well during her slide presentation. But it's things like, what's the sector doing to support BME communities who are particularly exposed to COVID? Why aren't we getting this PPE from government? How will we risk assess visitors if this lockdown goes on for a long time? If staff stay away for no particular reason, can we get them to come to work? How do you accept residents from hospitals if you haven't got testing to find out if they have COVID? Can you furlough staff who are shielding? And if so, who's going to pay for them? And on the furloughing itself, which is a real focus of people, can colleagues demand to be furloughed if they have childcare issues, or they're over 65, or they have underlying health conditions, but they don't have a letter from the NHS? All very practical questions. The other element is really just to look at the numbers. So workforce is the key cost to delivering healthcare. So Langbuisson developed something called care cost benchmarks with the Joseph Rowntree Foundation many years ago. And we looked at what was effectively a fair price for care. And you can see that in nursing care, in frail and older people, or in dementia, the cost of your workforce as a percentage of your sales is over 70%. And for residential care, it's over 60%. So actually workforce, if those costs inflate, has a significant impact on the viability of your business. So enough from me. I am delighted that we've got such a fantastic panel. We've got Mike Parish, who's the chair of Care UK, but also Achieve Together. So sits across elderly care and adult specialist care. And I think those two sectors have been very differently impacted, as he will expand on. Sam Leighton-Smith, who's a founding partner and director of Compass Associates, which is one of the leading recruitment firms in the sector and looks across social care, but also life sciences and other sectors. And Sam's been talking to a lot of the chief executives in the sector and some really good insight into some of the dynamics of how things are changing. Suhail Mirza, who's the author of the upcoming Langbuisson staffing report, which looks across both healthcare and social care, and has got some very interesting statistics to share with us, but also has been interviewing chief executives from across the sector as part of the preparation and the research for this book. And so we've got a really fantastic insight into what's going on. And Jodie Sinclair, who has been working very closely with many operators, is sitting on a number of their calls weekly, and has got an incredibly useful insight into some of the day-to-day challenges, but also I think some of the liabilities that people are starting to think about over the medium term as they run their business. So on that, I'm going to pass over to Mike, and I've got a few slides which I will click through, but Mike, over to you.
Morning, everyone. I shall I'll move fairly quickly because we're tight on time. So first, I just wanted to set the scene of our reality rather than the leg reports we get from the media and from the government. So KUK has lost to date around 5% of its residents to COVID-related symptoms. Around double that in terms of total deaths. We're not seeing a duplication. We're seeing an incremental impact of COVID-related deaths. If you were to extrapolate that across the sector, you get to 20,000 deaths currently. I'd caution against that because KUK has much higher dependency and is urban oriented. But even if you half that, you're at 10,000 and rising. KUK has also got just under 10% of its residents symptomatic. It's hard to get a grip of the mortality rate of symptomatic residents, but if we work on somewhere between 40 and 60%, you can see that the numbers are going to be material in terms of people that die in elderly care homes. And we've lost six colleagues, potentially from COVID-19. One has been tested and confirmed, the other 5 not tested. If I contrast that to Achieve Together, obviously much smaller operating units, smaller workforce groups, the proportion of people we support who have died from COVID-related symptoms is less than 0.2%. So hugely different, and one colleague has died. So we can speculate around the difference. I guess it's size of workforce that is the most obvious explanation of the difference. And obviously the real critical nature, the high dependency nature of residents in elderly care homes. Those would be the 2 major differences. And I read this morning that Professor Valence said that from the beginning they were aware of the issues and risks in care homes. Well, I've got to say there was no real indication of that in any planning that was implemented at the beginning. There's been lots of catch up. But if I go back to February and March, we were leading the way as a sector in terms of stopping visitors ahead of government indications and no prioritisation of PPE across to the care sector. So no real indication that they put any awareness into action. Very few admissions to hospital. I endorse that. I think that was on a risk assessment basis. That's very little point put in very elderly people with multiple conditions onto ventilators, and a recognition that care home is a much better place to die than hospital at the best of times. PPE and testing, we know all about it. We've been in the pecking order below hospital. Hospital was prioritised in terms of maintaining capacity, NHS capacity, ventilator capacity, ICU capacity, and all PPE and testing was directed, and everything else then followed, and domiciliary care behind residential care, and that's ongoing. Huge costs incurred by both the organisations I'm involved in, so £1.5 million and £1 million respectively on PPE alone, and rising, increased employment costs inevitably from higher absence and supplementary payments, etc. The 1.3 billion was handed across to local authorities by the government to support that cost. The approach from virtually all authorities has been to say, demonstrate your costs, and we'll think about recompense in the fullness of time. Clearly not as intended by government. I know many have. I've been working very hard with Helen Watley and Robert Jenrick to try and get that freed up, and just to make a flat fee allocation to all care providers to the order of 15%. I'm hopeful that something will happen there. I suspect they'll chip away at 15%, but I'm hopeful that every care home will receive a supplement to fees as a flat increase. Fingers crossed. And Henry picked up on it. We're looking forwards to the coming months, coming year or two in terms of impacts. Clearly, with quite a bit of speculation. But the concern for us is not just the obvious doubling of mortality rates and the impact of that on occupancy, but a no to slow admissions rate that we're experiencing, and really speculating as to when admissions to care homes will begin again. And even if you take a fairly prudent view, the economic impact on the care home sector is material. If you begin life in a fairly healthy state economically, you can get through it, but I suspect most people will be hitting covenant levels. If you don't start with a healthy economic position, I think you're in real trouble. A lot depends on when admissions will recommence. So if I move on to the next slide and pick up some more operational challenges, we've seen colleague absence in both organisations peak at around 12% and come down to 7-8% now, and falling as people cycle back. I would note that absence in public sector organisations in the NHS particularly has been between 20 and 30%. And I do worry that the sick pay schemes have influenced that. I hope not. I really do hope that our workforce hasn't been coming to work when it shouldn't have been. To an extent, people are more likely to take time off when they've got a full sick pay scheme. But that sickness rate difference, I think, is notable. The latest PHE guidance on PPE, we would endorse in both organisations. We think it's sensible, but there's not enough PPE to meet its specification. We have sufficient supply in both organisations, but the period for which we've got sufficient supply has reduced with that new PHE guidance. So clearly, dialogue with government is ongoing to try and align resource to policy. From a workforce point of view, we're seeing a significant increase, to the level of 50% for support worker job applications, and obviously a much more expedient process to onboard people, DBS checks online, etc. How that converts to actual new employees, we'll see. I'd expect a significant fall off from that as we go through the process, but it's encouraging to see that uplift. However, applications from nurses and experienced care colleagues have reduced, and I'm not surprised by that because I think people are sticking where they are, not a time to be moving. Clearly, there's unprecedented interest in the sector. We're seeing the Department of Health and Social Care career advertising commencing, and the political interest in professionalisation and pay levels of the sector is as I've never known it before. Clearly, the feedback we're giving them is that, yes, we want to pay more, we want to professionalise more, and we need their financial support to do so in fee levels, and not to just impose obligations on us without supporting that in fee levels. And also, I'm concerned about future litigation risk, whether from relatives or from colleagues, and concern as to whether we can get some kind of indemnity from government where we have met contemporaneous guidance. So I'll close there.
Mike, thank you very much for that, for sort of setting the scene very much from an operator perspective. I'm now going to hand over to Sam Leighton-Smith from Compass Associates, and just to sort of set the scene from his perspective, to give us an idea of the breadth of the dialogues you've been having across the sector, Sam.
Thank you, Henry, and good morning, everyone. So Compass Holding Group, which is comprises of 3 business entities, which you can see in front of you: Compass Associates, Compass Executives, and Compass Corporate Services. To simplify them, Compass Associates is what I would describe as a middle management recruiter of permanent staff to the independent sector. Salary brackets typically range from 35 to 100,000. This is the biggest hub of our business. We have divisions in every part of the sector, so that is the elderly care space, in all of the social care space, I should say, all of the healthcare space, and then also the life sciences space also. The Compass Executives is, as you see, it's a C-suite level search firm. We work primarily with investors, and we have a prevalent not-for-profit part to our organisation as well. In addition to that, we have life sciences also, which is very European and overseas based. Compass Corporate Services is a corporate head office recruitment function. So we place everything from HR, finance, property estates, training, L&D. And between the 3 organisations, we have really good visibility of the sector from every single part of it, from a chair perspective all the way through to a frontline worker perspective. The next slide, please, Henry. So what I want to try and get to here is just give you an overview from a recruitment perspective across the sector, and how quickly things moved and how quickly the health and social care sector space moved with that. So as you can see here, these are just some headlines, but on the 11th of March, the Chancellor only announced originally 12 billion as a COVID package. And when that happened, especially in the healthcare arena, that surgical hospitals, everything from dentistry, veterinary, ophthalmics, dermatology, podiatry, interviews suddenly paused or were cancelled. And that was as the significance of the situation began to increase. I put here consumer health considered its options. So in light of the risk to staff, a lot of the consumer-based businesses started to put a complete pause indefinitely on their recruitment as early as 11th of March. 5 days later, Boris obviously urged home workers, and many businesses' central offices started to relocate to home working. That in turn, especially from our Compass Corporate Services business, put a pause on future recruitment for head office recruitment indefinitely until we got through this crisis. And all of our client meetings were naturally shelved due to the threat posed by COVID. 1 day later, the Chancellor announced up from 12 billion to 330 billion emergency package for the country, and the consumer health part of the business ground to an absolute halt. Obviously, schools and nurseries, key workers aside, closed down, and many industries from retail, transport, hospitality, food aside, closed down as well. I put 17th of March to present because during that time, there was, as Mike alluded to, a 50% spike in social care applications. This webinar is primarily focused on social care, which is children's residential, adults and elderly, whether that's community or residential care. And I put here on the observations that for the first time in my 10 years of being within the sector, social care has parity of attention with healthcare. And that uptick to 50% in applications is a phenomenal increase. I put here the digitalisation and recalibration of the recruitment process. The sector's actually been really nimble and they've moved really quickly. It's always been argued that, especially in social care, they've had quite antiquated processes. Well, with the online DBS, and now people are looking to interview people digitally, and only at the very last stage, when they're looking to make a hire, will a face-to-face with safety measures in place take place for frontline workers. I think the sector moved remarkably quickly, as quickly as they did from the Southern Cross crisis in 2011. The next one I put here is retention and recruitment. We've always, whenever we've partnered with a client, we've always talked about recruitment being a retention process first and foremost, followed by recruitment. And what we've always tried to rationale with our partner clients is retention was actually probably more pertinent to employees than the recruitment at the time. Recruitment was a very reactive process that was to fill the gaps. And if you walked into care homes especially, they'd have an in-tray of applications that were just not answered. And there was a shortage of support workers, shortage of nurses around all of the social care arena. This is the first time I can remember where recruitment actually can be a priority now, where you can overstaff, staff flexibly, it's always been quite rigid in terms of hours, and then move on to the retention piece. And I think that's quite a flip from where we've been previously. It was always the door to the sector, people always concentrated on the healthcare side of things and maybe stumbled across the social care. That has rightly changed now with the attention and the microscope that is on social care. Speaking to businesses, it's subtly different, but in the main, children residential and adult social care businesses, speaking to many chairmen, chief executives and managing directors around the sector, their staff morale is at an all-time high, partly due to the recognition that the sector is now receiving. I think this is also extremely important because the Health and Social Care Secretary, Matt Hancock, and his predecessors, they've always been health secretaries, and social care was kind of brought to the fore if there was a scandal. And now it's been quite rightly recognised as a hugely valued add to society and communities, and the morale within the staff workforce seems to be ever increasing. Within the aged sector, the elderly space, there is slightly mixed reports. Some providers are saying that, inspiring stories of workers really working to the bone in terms of through the crisis. But we have had slightly mixed reports in terms of the morale and the team spirit from company to company. But definitely within the adult and the children's social care, we recognise it's an all-time high. I put here in terms of social care must not emotionally recruit and stress test. With so many applications and people especially coming from the transport sectors, the retail sectors, the hospitality sectors, in industries that have closed down temporarily, and with applications so high, I think it's really easy to recruit quickly but not smartly. And I think social care providers, while they've got this uptick and surge in applications, should really try and stress test people's appetite to work in the sector long term. This is probably the opportunity that I've seen in the last 10 years where you can overhire and, as I touched upon, hire flexibly and there's a lot of talented workers out there who want to join the sector and have only recognised the sector due to the crisis. And they've actually realised in certain cases that it's a wonderful sector to work in. And I think it's really easy for providers just to recruit quickly, but as soon as maybe business returns to a supposed normal, these people might suddenly leave. So how you stress test and graphically explain the responsibility that they will have within the sector, I think it's going to be really important to make sure that your staffing levels are maintained during, post and after the crisis, especially if, as reported, there'll be a second wave. Other observations from an investor perspective, investors, anything that was sort of pre-acquisition, the majority, unless it was a distressed asset or opportunistic investment, predominantly was paused for the time being. But we have seen a lot of investor appetite for pipeline interviewing and looking to meet individuals with a view that if business does return, that they have a pool or a bank of high caliber personnel ready to choose from. We are finding that some, especially in the healthcare space, if they are being strategic, they are actually looking to do their recruitment now whilst there is a wide and deep pool of people to select from, because so few providers are recruiting, especially in the healthcare arena. Other observations that lastly I put, we've just vanity consumer health, where our expectation is that in the mid to long term, that this is probably the sector, this includes dentistry, I think private dentistry to some extent as well, but especially anything cosmetic or aesthetic, this will probably be the one industry we expect to have some troubles. And if you were going to call a winner in the future from this crisis, I would probably say investor appetite from who we've been speaking to, both nationally and internationally, will probably centre on the adult social care and the children's social care arena. The last thing I wanted to touch upon was the opportunities for social care, and I think this is a wonderful opportunity for social care providers to really showcase the value of working within this particular industry. I don't think people have recognised it as much as they do now, and as I alluded to, there's a lot of talented people out there who want to join the sector. And with morale, in conjunction with morale being at an all-time high, this is just a wonderful opportunity to showcase how rewarding, how value-based, and how professional the industry is. And it's a great opportunity for providers in an upbeat environment from a recruitment perspective to really showcase that. And I think from a career opportunity, it's probably the key time where those career pathways that people have talked about, but not necessarily provided much focus on, this is the time when they really can put a career pathway into place, overhire or hire very talented people, and make it happen in the long term. I touched on below strategic recruitment of staff. In social care, people are walking through the door, that's great, but it is obviously in the healthcare side, via the investment point I made above, it is a good time to strategically hire. The career programs, I think that's across the board, is just a good time really with such exposure to show people what type of career they can have in the early, mid and long terms. And just to reiterate the point below, I think investors and infrastructure funds will maintain their interest in social care for the foreseeable future.
Sam, thank you very much for that. I think what you're showing is it's actually quite a nuanced picture out there. There are winners and losers, but equally there's a huge opportunity for social care just because of its enhanced profile to really recruit perhaps people they would never have had access to before, which is again a positive coming out of this. What I'd also say, just picking up on your last point about investors and particularly infrastructure investors, they've been looking at social care as social infrastructure. And I think a number of them have been quite skeptical about whether they've really been essential services. And what social care has shown is actually it's been incredibly resilient through the pandemic so far. And I think that's surprised them. They've bought into things like airports, for example, which they thought were essential services. And they're finding out that airports can be shut down. So I think for our sector, there are positive aspects out there. On that, I'm going to now pass over to Suhail Mirza. Suhail, as well as being the author of our staffing report and consultant to Languisol, has another hat, which is the chairman of Retinue, which is also very active in healthcare staffing. So Suhail, I will pass over to you.
Thank you very much, Henry. I think it's important that we take a global look at the workforce supply issue, because I think this was a key thing from the poll that you've been running. And what I'd like to do is look at the pre-COVID context briefly across both health and social care. Taking a global picture, we have to understand that the fourth Global Forum on Human Resources met in Dublin 2.5 years ago, and it predicted on current demands that we're going to fall about 18 million healthcare workers short by 2030. This is across the globe. And that's effectively a 20% shortfall. So whatever strategies we're adopting in the short term and long term from a policy perspective, we have to face the fact that we either need a 20% increase in productivity or a 20% increase in the number of workers. So that's the broad context. Looking at the NHS figures, these are not going to be new to most people. Prior to the crisis, 100,000 vacancies across the NHS at a vacancy rate of 8%, and that's much higher for nurses, 11 to 12% increase from 2017 to 2019. So these are significant numbers, and in London and mental health trusts, 12, 13, 14, 15%. When we look at the nurse numbers, of course, you see there it's 43,000. That's the latest figures that we've seen from the National Audit Office. Turning to social care, which is our focus here, Skills for Care identified over 120,000 full-time equivalent vacancies in their report at the tail end of last year. And that's significant in terms of the numbers, but also the rate, which continues to increase, particularly amongst senior management. And if you look at the turnover rate, I think that's particularly interesting, with something like 440,000 people churning in their roles. And this is across all of social care. A caveat there is that some 2/3 of those do get re-employed within the sector, so we're not leaking all of these numbers. By contrast, discussions with Scottish Care yesterday, their stability index tells us it's 72% of people across the social care space there tend to stay in their job if you look at the previous 12 months. So perhaps something instructive, and that I think may relate to the dreaded F word, which is not furlough in this case, but funding, because obviously the living wage provisions in Scotland are generous compared to England, and that may have a bearing on that. I also wanted to touch finally on the workforce wellness point, which we'll go into a little bit more detail in the next slide. This is a profound issue across the healthcare space. The evidence prior to the COVID breakout shows 38% of NHS staff absent through work-related stress. The estimated costs are anything from £300 to £400 million, depending on which source you adopt. And that is a massive issue prior to this crisis. And I want to circle back to that on the next slide. Again, the social care pressures we see here, people turning to alcohol, etc. So these issues are played out on a global and national and regional context prior to the COVID crisis. Now, if we move to the next slide, I wanted to highlight a couple of things to draw on my couple of roles, as you mentioned. As the author of the Langbuisson UK Healthcare Staffing Report, which we're drafting now, I've been very fortunate over the last few months to spend time with dozens of chief executives within the NHS, chief executives in the private healthcare, private acute, as well as social care field, as well as policymakers. And I want to draw a few of those themes out, if I may, as we walk through here. The first 2 points relate more to practical imperatives. The Skills for Care have run this survey, which they shared at the beginning of this month, showing actually significant rates of absence. And that does vary according to providers. And Mike alluded to the numbers falling in Care UK. We're seeing numbers of around 25%, but that can vary from 0 to 50% in some cases. So that remains a really powerful issue in terms of workforce supply. And of course, there's an urgent need for that. Turning to the work, what does this mean practically? What's been happening on the ground in terms of the poll which asked for workforce supply issues? I've highlighted there initiatives to secure staffing supply chains. Now, what do I mean by that? With my chairmanship at Retinue Health, what we've been seeing is a demand from providers, and this is both NHS trusts in clusters and individually, as well as providers in adult social care, specialist care, and private acute. What is happening at the moment is supply chains need to be expanded, and access is given to workforce, clinician workforce and non-clinician workforce. So what Retinue has done there is data-driven analysis to help them and access a wider supply chain. Furthermore, a tech-enabled platform which has helped not just in terms of ensuring that compliance and safeguarding issues are not undermined, but furthermore that actually financial safeguardings are in place, because in a very febrile atmosphere, it's very easy sometimes for those back office processes to become a little bit slack. So financial fraud, etc., and also the broader themes of policy which relate to pay rates, frameworks. These are issues that some of the clients at Retinue are very keen to ensure that they do not breach unless they need to do so. And in some of the work in the social care, the clients have been actually keen on looking at permanent recruitment. And as we now pivot, one of the latest findings that we're having from the conversations I'm having with chief executives is now there's beginning to be attention across the spectrum on the restoration elective. What effect is that going to have in terms of workforce now, and how do we draw upon that? The other things there we've all touched upon there is retention and integration. Stephen Dorrell quite rightly highlighting the fact that we've got to ensure that retention remains an issue. If we're going to be 20% short in terms of productivity, we must retain the existing staff. And I think part of that idea is that NHS England are trying to draw their retention rates much, much higher. And that will require, in terms of recognition, as well as career paths and newer roles, and that will apply in the social care sector too. Funding speaks for itself. We've heard from Mike Parish earlier that the planning didn't seem to be indicative of what was coming. And I think what we've seen here is that one of the great things about the COVID situation is the enormous amounts of money that have been immediately implemented by the government for the NHS, writing off £13.4 billion of debt, £1.3 billion of emergency funding. And I think if there's such a thing as herd mentality in policy in social care, well, I think everyone in social care has developed a herd mentality in respect of any new initiatives for green papers and other commissions of any sort. As Martin Green has indicated, the underlying trend will be that unless we're adequately funded for the immediate cash flow requirements that Mike alluded to earlier, we're going to, as a sector, the social care sector is facing a significant challenge in the immediate term. And longer term, these are not new figures. The House of Lords Economic Affairs Select Committee, July last year, set out what it called a national scandal. And we know that these things now need to be addressed. We talked earlier, Sam mentioned parity of interest. And I think that's right. There is a parity of interest, but it's come late to the party if we look at the timeline since March. And people like Jane Townsend in the home care sector from the UKHCA is strenuously promoting the idea of parity of esteem, and that will apply across the whole of social care. One of my former roles in my former lives is I ran and owned a family home care business. So at that time, there were so pressures in terms of reaching budgets, providing for pensions, living wage, and those have become more acute as the figures show that the social care budgets have been strained by 13% in real terms over the last few years prior to this year. So I think the parity of esteem is a very important issue, and whilst recognition is being given now, I think it's important. Should there be a Royal College of Carers? Well, they're part of the front line, the infantry, if we want to use the war metaphors, in this war against the silent enemy. And it's instructive in my conversations with chief executives in the social care sector and policymakers that when the government, quite rightly in its manifesto, highlighted many commitments to the NHS, including, of course, the long-term plan and the people plan that we're hoping to see in final form, there's no recognition or connection to a people plan for social care. And I think, absence that, what is the efficacy of a people plan for the NHS? Because the connection between those two sectors is profound, inexorable, and inevitable. The one final point I'd like to make, and this is coming again from policy papers, but also discussion. I am working very closely with NHS trusts in particular, but also now in social care and private acute hospitals, that the idea that it is a great deal of interest, but there is a significant impact now on the mental health and well-being of the workforce in both health and social care. Evidence internationally from pandemic outbreaks suggests that that impact is quite profound and can be delayed. So when there is a new normal, we need to be fully aware of what that might do in terms of current workers and how we're going to cope and help them cope with the trauma that in many cases they're suffering. So I think those are themes which have run through all my conversations in recent months. And the wellness point, I think, is something from a supply point of view, all of us as providers and policymakers and citizens need to be very much aware of as we transition back to a restoration of more normal service.
So Hill, thank you very much for that. I think that actually sets the scene very nicely for Jodie, because I think a number of things you've touched on there, particularly, as you said, around wellness, mental health, some of the liabilities actually that people think of when they're looking at their workforce, and that is alongside all the PPE and the testing. I think if you're a director of a provider, you have to have an eye to what the regulators saying, what the law is saying, and what's really happening in the real world. So Jodie, over to you.
Thanks, Henry. Well, certainly in terms of the workforce issues that we're seeing come through and we're advising on, is that it is covering the whole spectrum of employment law issues that you would expect to see in this situation. But what's unique is that the spectrum of issues being dealt with are all at once, they're at pace, they're alongside new legislation and ever-changing guidance in relation to some of those key issues we're seeing that have emerged over the last 4 weeks that providers are trying to adapt to and meet as you deliver that safe service to your service users, but also your staff. We're seeing overlapping considerations and competing priorities and tensions, particularly, as other speakers have mentioned today, taking into account the well-being and health and safety considerations that need to be considered, particularly around and in light of the PPE, the testing, but actually that your staff are witnessing and being involved in increasing mortality on a daily basis. And we don't know the long-term effect at this point in time that that's going to have on staff. And whilst we've heard anecdotal evidence around the morale being high and certainly the social care sector stepping up to meet the challenge, recent surveys by Skills for Health and the IPPR, we've got 25% of adult social care workers who are aged over 65, so potentially at higher risk. We've got currently 4% of the workforce shielding and 6% socially distancing. 50% of healthcare workers are reporting that their mental health has deteriorated since the crisis began. And 1 in 3 are saying that their physical health has also declined since the crisis began. Now, it's welcoming that the government has extended the support that's been provided to NHS staff to social care staff. So the free-to-call support helpline, the new care website, and the app for the social care workforce that should be available by the end of the month. And yesterday, the government announced death in service benefits available to health and social care staff in terms of a payment. And I think that we need to just be very mindful that the Coronavirus Act and all of the supporting guidance or supporting legislation that's come in doesn't replace or trump the existing legal framework that you are operating in as you manage those workforce issues. So there's still duties under the Equalities Act, there's the health and safety at work obligations, which I'll touch on in a moment. Your staff will have whistleblowing protection if they are raising concerns about health and safety, and clearly PPE and testing will fall into that. And of course, where staff are concerned or they're lodging grievance, you will have a duty to ensure that they're being dealt with. Because what we don't know is to the extent that while staff are stepping up to the mark now, to the extent that they're going to try and seek redress down the line when the situation ends. I mean, what we are seeing is that with the latest guidance, I mean, we're on the 6th iteration of the furlough scheme guidance in the space of 4 weeks, is a number of contradictions and discrepancies. So as providers, you are having to take essentially a commercial risk assessment in terms of how you're managing some of these issues at pace in order to provide that service. I'm not going to go into the furlough scheme. I'm going to assume that you know what it is, but I want to pick out some of the key issues that we're seeing coming through, and particularly around the shielding point. And I know there's been a number of questions and the interplay between the guidance, the directions, and how that works with the furlough scheme in particular. So we have extremely vulnerable groups that have been defined by PHE guidance, where there is a recommendation that those groups shield for a period of 12 weeks. There should be, and the expectation is that there is an NHS letter categorising those staff as extremely vulnerable. Now, the HMRC guidance in the latest iteration on the 23rd of April post-dated the Treasury direction to HMRC, which came out on the 15th of April. So the HMRC guidance says that you can furlough shielding employees, or those staff who need to stay at home to care for someone else shielding and they can't work from home. The Treasury direction, though, which came out on the 16th of April, which doesn't appear to have retrospective effect, however, says that shielding employees are entitled to SSP. So there's that contradiction there. Now, as I said, it's about a risk assessment, and given some anecdotal feedback from HMRC, my view is that you can nevertheless furlough those shielding staff. The commercial risk, however, is that you may not recover that 80% rebate, but I consider that that risk is low. In terms of vulnerable groups, so we don't expect that there's a letter from the NHS determining that you're fall within the vulnerable group. PHE guidance is those staff should socially distance, so avoid where possible non-essential public transport and work from home where possible. Those vulnerable groups are not entitled to SSP unless they are shielding or self-isolating. The HMRC guidance is silent on whether or not you can furlough, but it provides that you can furlough for business reasons. So arguably, my view is that you can furlough those vulnerable employees. For pregnant employees, I know you're managing a number of those, you have additional duties under the health and safety regulations to carry out risk assessments, to alter working conditions, to alter hours, to offer suitable alternative work. And if that's not possible, you have a statutory obligation to medically suspend those pregnant employees on full pay. Now, my view is that you can furlough pregnant employees, but actually, on balance, you should be topping up to the full salary. Otherwise, there is potential risk exposure to employment tribunal claims. A word of warning for zero workers. This may apply to zero workers where you've got those category of 0 hours who may satisfy the employee status test. I want to also acknowledge, and I think it's absolutely right, and it should be, the disproportionate impact on the BAME workforce, where there is 63% of cases across health and social care where the workforce is from a BAME background. Now, the government has announced an inquiry in a number of recent days as to the impact across both patients who've passed away and staff. Interestingly, Somerset Foundation Trust have just announced that they are including all BAME staff in the vulnerable and at-risk group and giving them priority access to masks, for example. Other queries we're seeing coming through on the furlough scheme, whether we need employee agreement, obviously where you are receiving public funding for staffing costs or for services directly related to COVID, the expectation is that you will not furlough, but there are some cases where this would be potentially justified, and I think arguably that would apply where you are having to shield staff. Annual leave has remained an issue there. in terms of entitlement and whether you can require staff to take leave. But the key point is, if staff take leave during furlough, you need to pay them their full contractual salary. In terms of some of the longer opportunities, challenges and litigation risk, I'm not going to talk about the opportunities that's been dealt with by other speakers, but certainly, as I said, we don't know how staff are going to feel after the COVID situation has passes. They are admirably stepping up to the challenge at the moment, but I think arguably we are going to see potential retention problems. There's certainly a report that I think what IPPR YouGov poll, 1 in 5 healthcare workers are indicating that they're going to leave the profession after the pandemic ends. I think it's likely that we will see a spike in sickness absence, and as Sahel mentioned, the impact on stress, potentially post-traumatic stress disorder from staff who've been on the front line. Certainly in terms of managing employee relations issues and dealing with the whistleblowing detriment. I think in terms of just finally on the health and safety issues, I mean, certainly the regulators are advising and recommending that providers should do their best. I think it's safe to assume that the bar is lower than it normally would, but what we don't know is how far lower that threshold is and whether do your best will be deemed to be good enough down the track. But from a practical point of view, carrying out risk assessments, keeping an audit trail, being very clear on the decision-making process and recording that, engaging with staff, communicating with staff, and cross-checking with that applicable guidance. And whilst it's changing, ensuring that you are complying with the guidance as it stands on that particular day, to show that you've taken all reasonably practicable steps in terms of that litigation risk should it arise. I'll finish there, Henry.
Very good. Thank you very much, Jodie. We are now going to move to Q&A, and the Slido has been working in the background, so hopefully you can see those questions on your screens. I'm actually going to start with Mike, because I think 2 of these questions: are you looking to increase private client fees to cover additional costs? And what's your view of when confidence in care homes will return and we'll see admissions start to pick up again? I think that's very much, I'm sure, a focus for Care UK in particular, where you have a significant number of private pay service users and residents. And also in terms of confidence, just because at some point you will need to look to build your occupancy again. Mike, I didn't know there's a sort of definite answer to this, but I think it'd be really interesting to get your views, certainly in your perspective.
Yeah, views. I mean, speaking personally, it doesn't feel like a sensible time to be increasing private fees. I think we need to work hard with government to support our increased cost base, and then see how things develop over the coming months. When will admissions recover? Very hard to say. I worry that that there's going to be some deep-seated concern around the safety of care homes, given the publicity that the reality is going to attract. I think it's for us to be compelling about the actions that we will be taking to make our care homes safe. So in terms of hygiene, infection control, and giving confidence to prospective residents and relatives that it is a safe environment for people to come to. And ultimately, people will be faced with least worse situations, won't they? Not being cared for, well enough at home, going into hospital, or coming into a care home that provides reassurance.
So the next question is really around pay, and Sam, I'm going to put this to you. What will be the implications on pay going forward? We've heard a lot about how the esteem, the status of the sector has actually been enhanced because it's actually being recognised publicly in a way that it hasn't before, and people are seeing day to day what people are having to do on the front line to keep social services working. But are you seeing, in terms of the flow and the conversations that you're having with CEOs, that there is any indication that pay will increase, or actually perversely is it the inverse, that the local authority funding is where it always has been, and actually there are more candidates rather than fewer candidates, so that changes the balance of the negotiation?
Well, I think during this period, in terms of pay, that hasn't been a barrier to people having an appetite to want to take a position within social care, because the rates are comparable to the sectors that they're coming from. So I don't see that as the issue. The funding issue will always remain the key hurdle for providers. If they have more funding, they can pay their staff more money. So I think that the funding question will be the more prevalent one, as opposed to the pay for the workforce. As I said, will the pay and the reality of working in social care, people who come from outside the sector, will that change their perception once there's other opportunities in other markets again? That'll be a question that will play out in due course. But that's where the opportunity for social care providers is to show what a valuable place of work social care environments can be.
Very good. Jodie, there are a whole series of questions for you, by name in fact, from Anonymous here. Jodie, can a staff member who's living with someone who's required to shield be furloughed?
Yes.
That's an easy one. Very good.
I'm looking at the clock, so fastest buzzing first.
We've got another one here. Is there likely to be any national PHE guidance on prioritising PPE and equipment for BME staff or BAME staff?
I mean, I think that's a difficult one to predict. I mean, I think it's welcome that they've announced the inquiry in a matter of days. I think certainly this issue is getting greater priority, and I mean, the guidance comes out with very little notice, but I think certainly bearing in mind equalities issues feeds into the well-led agenda for CQC considerations, the workforce race equality. I think it needs to be promoted around what the expectations are.
Very good. And then just the guidance around furloughing for people who are receiving public funding. And I guess this is particularly relevant even for the dental sector, where we know that people are continuing to receive most of the funding for units of dental activity, and they're not allowed to furlough their staff.
I mean, certainly the guidance, there's been very little change to the guidance in the 6 iterations we've seen. It says there's the expectation that they will not be furloughed, but there will be some exceptional cases. They haven't given examples in any of the guidance as to what those exceptional circumstances are. I think where we have services which are mixed, so privately owned, but with some public funding, to keep an audit trail around how that funding pipeline is managed. Is it for staffing costs or not? I think the safest bet is to be furloughing staff who are shielding rather than furloughing whole bunches of staff. But that does mean a financial implication for the provider, but whether or not there are other means by which they can access government support, as opposed to relying solely on the 80% furlough scheme. If they do, there's obviously a P&L risk that they will not recover that rebate back. There's also potentially an option to not pay the staff until they get the rebate, but there are other considerations around that in terms of managing the risk. I'm happy to pick that up separately because I'm mindful of the time.
So I think we've got literally a minute left before the 11 o'clock silence. So I might just go to Alan Rosenbach's question, which is, what do the panelists think about the emotional impact on frontline staff and leadership teams of dealing with this emergency? Because it does affect everybody. And I think you've got about 10 seconds each. So why don't I start with you, Mike, as the chair of 2 large providers?
I think listen to people, give people the opportunity to express themselves.
Suhail, we take you off mute.
To have structured plans for all levels of staff, including the leaders, to support their emotional well-being. This will be redound for the benefit of the sector over the next few years.
Jodie?
I mean, I think plan now and action now, and certainly what can be taken advantage of now. We're hearing that mental health trusts are going into acute trusts. What can social care also take advantage of if we're talking about a truly integrated system?
Very good. I think it's now 11 o'clock, so thank you all very much. Our next webinar's on home care on the 7th of May at 10 o'clock, but thank you.
Thank you.
Thank you.